actually diagnosing it before we operated on it. So is my screen sharing?
Not yet. Just want to hit that share button again like we practiced.
All right, let me get out of here real quick. Share. Okay. And then I'll open her up here. Did that work? Can you see it yet?
Not yet. Yeah, not yet, John. You hitting the green share?
I did.
Then some windows should pop up and you just grab the one that's got your slides in it.
It's not working again.
It's encouraging. Nope.
How can you see it now?
Just put it into full screen mode.
There you go. All right.
Okay, here we go.
John.
All right, a little bit of primer here. Osteoporosis, of course, is a decrease in bone quantity. You have less bone trabeculi. It's not as strong. It's often related to a lot of environmental problems, a lot of syndromic kind of things, metabolic disease, and of course, it's genetic. Osteomalacia, why I mention that is they're frequently together, particularly in people with liver disease, alcoholics being prototypical. And so you have simultaneous disease a lot of time. So you must be a bone detective when dealing with cases of poor bone quality. You really need to look for this before you operate on people, particularly when you're doing adult spinal deformity. And you make the diagnosis pretty simply. Any previous fracture, basically a broken hip, they probably have osteoporosis by definition. You can also do a DEXA scan. In addition, of course, frac scoring. And of course, for us as spine surgeons, we frequently get CAT scans, so we can do optimistic CT scans and look at the HUs. The frac score is relatively simple. You can get this in your office. It has a lot of risk factors and a lot of, if you've had a previous history, your family history, and it's a very good way to make a very simple, non-invasive diagnosis of osteoporosis. However, we have a lot of tools now. We have DEXA scans, CAT scans, and even MRIs have programs that can be put on that are early in the ability to tell reliably whether or not you have osteoporosis. But certainly the DEXA scan with the broken bone scanning done at the same time, the score is very important. And of course, the CT scan has the classic Hounslow units, but also you can do quantitative CTs and biomechanical CTs to assess it. The workhorse, of course, is the DEXA scan. It's a dual energy machine. It basically tells the difference of the bone, high and low measure, the difference in absorption, and it'll tell you your T-scores and Z-scores. Basically, when you look at this, a T-score compares you to a healthy 30-year-old adult, and a Z-score is what you use really for younger people, particularly children, and it's age matched to your peers to see how you stack up against them. And it's measured, you've all seen this. Basically, you want to be above 2.5. Anything below this is diagnosed as osteoporosis. However, I must point out about half of the fractures that occur in the spine are in the osteopenic range, which is between normal and minus 2.5. So we probably should be treating these people earlier. This is basically the diagnosis, minus 1 to 2.5 is osteopenia, and more than osteoporosis. And if you've had a fracture and it's less than minus 2.5 on the DEXA scan, it's severe osteoporosis. So basically, about half the fractures I mentioned are in the osteopenic age. So really, as you can see, the risk factor doubles with every standard deviation of the DEXA scan. So you can see that if you go to minus 2, minus 3, you're up to, and finally minus 5, you're going to get a fracture almost for sure if you have a minor fall. And we're going to show you a couple of cases of that today. When you look at the distribution of fractures, they obviously go up as you get older. And of course, that correlates with the fact your bone mineral density is decreasing and your T-scores are dropping. So when you look at the trabecular bone score, you can do this on your DEXA machine. It's just a program, and it looks specifically at the vertebrae, and it looks at the trabecular microarchitecture. And a lot of times, some people just seem to get a selective worsening of that, and that will result in people that get these multiple compression fractures. You get one, 50% chance of getting another. If you get another, you've got a 100% chance unless you institute treatment. And if you operate on these people, you're going to be in big trouble. So look into the trabecular bone scan. You can do it right on your existing machine, and it really add a lot of information. And it's scored, and basically, if you get a less than or greater to minus 1.2 on the score, you've got degraded bone, and you need to check them out maybe with, because it's, if they have osteoporosis, it's done concurrently with the DEXA scan. Now, CT scans are what you really should be using. Many of our patients have myeloid CTs, and the myelogram minimally affects a DEXA score, by the way, or also the HU units. But the bottom line is you can measure this on the axial is the best. Sagittal can be done, but it's a little bit less. And as you can see, it's a standardized measurement. It basically is compared to a lot of unknowns, and all the different tissues have various degrees of this that you can look at. But the Hounsfield units are strategically important, and you'll be able to measure them. So when you're measuring your pelvic incidence and your lumbodordosis and your spondylolisthesis, you really takes no more than 15 seconds to do an ROI at L1, L2, L3 and get an idea of what quality of your bone it is. And you can see that HUs basically decrease with advancing age, just like your DEXA score goes down. And here's a good graph to show you, and it exponentially starts to increase after the age of 50. So Hounsfield units are also very useful in predicting fracture. This is another study by Lee that basically looked and showed that less than 90, you get spine fractures a lot, and the same thing's true less than 97 with hip fractures. And as you get older and you follow these patients, the worse their bone, the more likely they are to get a very minor fracture falling from height. And we'll show you an example of that. So really, when you look at basically, you want to be for an adult spinal deformity probably over 160. When you get down to 112, you've got severe osteopenia. When you get down to 78, you've got severe osteoporosis. And if they're below 50 on their Hounsfield units, you better avoid elective surgery on them. And that actually was a board question that we recently had. So if you want to, there are several different nomograms available. You convert CTs to matching DEXA scans, as you see here. And basically, you can see that Hounsfield units, that when they get to be about 97, it's about a DEXA score of about minus 2.5. So you can look these values up and sort of put them in your mind. Again, remember, basically Hounsfield units less than 135, some people 125, but certainly in that lower area, they're probably starting in the osteoporotic range. So why is this important? Hounsfield units will predict bone-related complications. It's pure and simple. There's multiple studies now over the last 5 to 6 years, particularly out of Japan, that show that as your Hounsfield units drop, your number of complications dramatically increase, particularly when it's less than 110. So keep that in mind when you're operating on these people. When you look at all the complications and summarize, you can see the pedicle screw loosening, cage subsidence, total disc subsidence, sagittal imbalance because they get little micro end plate fractures and a little bit of segmental kyphosis at every single vertebrae, and you get a round back. PJK is the bane of all of us that operate on adult spinal deformity. You get pseudoarthroses and secondary fractures, as you can see on the right here. So your eyes only see what your mind knows, okay? So you need to think outside the box when you have these patients come in and make sure that you evaluate them before you operate them, unless it's an emergency, then you treat them immediately to make sure they don't have something that's treatable. And then you probably want to pre-treat them yourself or with a good nurse practitioner after you set up a fracture liaison service. So here's an example. Here's a 57-year-old female that comes in and was referred to us for back pain. Okay, she had a previous history of this is what she looked like 10 years ago. And she comes in looking like this 7 years later. Well, that's a pretty dramatic change. And she's had a kyphoplasty done without a diagnostic workup. So when you start looking at her, you notice something else too. Her bone is so soft that her sternum is actually buckling. And you'll see this with very advanced osteoporosis. In this case, it's almost certainly going to be metabolic. And when you see these people, you should think of the parathyroid gland. And you see every vertebrae is fractured. She's got the sternal buckling. You can read a newspaper through her vertebrae. And basically, when you check her HU, she's way down around -6. But when you see this, they've almost always got hyperparathyroidism. And she's at risk for a fracture. And so when we checked her PTH, it's elevated dramatically. And basically, when we looked at her CT scan, you could actually see the adenoma that was actually read on one of the CAT scans of her spine. And basically, there's nothing you can do for this surgically. Now, here's another 59-year-old female who comes with aching back pain and was referred to us without much of a diagnostic workup. And she basically was referred by an orthopedist because of her back pain. And she's a smoker. She did have a fracture when she was a child, so you certainly can think of osteogenesis imperfecta. Okay, but basically, when you look at her here, it looks kind of normal. And you look, now you start to see that she is osteopenic, at the very least osteoporotic. She still maintains adequate, but you can see her bone just doesn't look normal. So when you get your CAT scan, this is what it looks like. It's some sort of marrow-placing lytic kind of lesion. But she's not really sick. She doesn't have, something like you might suspect myeloma. You do a serum protein electrophoresis on us and it's normal. So this is a patient, even with a PET scan, it doesn't light up like some sort of tumor. So it's a very slow, insidious chronic problem that you see. Her MRI shows also areas, islands of abnormal tissue in almost all her vertebrae. So it could be metabolic or it could be some sort of systemic disease of some sort. And so when you look at her MRI, you can see it's normal all the way from her cervical, thoracic, and lumbar spine. It says metabolic or some sort of systemic disease. So when you check her DEXA scan, well, not surprisingly, she's low. Her T-score is down. And so you start thinking about all these things that you might want to consider. So these kind of people a lot of times will require a biopsy to see what's causing their bone destruction or metabolic bone disease or osteoporosis in this particular case, if it may be some other problem. And so she turned out actually to have histiocytosis. And when we biopsy her, it comes back and says she's got basically histiocytes everywhere. And it's probably been a lifelong problem that she's had since she's a kid. And basically, this was her diagnosis. So remember, in order to get around this and treat these people properly, I highly recommend you set up what we call an FLS, a fracture liaison service, or what else, preoperative optimization for bone health, whatever you want to call it. And basically, if you have an acute low-end fracture, energy fracture of anything, like we're going to show you a good example of that, a positive fracture score, or other risk factors, including smoking, family history, celiac disease, bowel disease, then you ought to proceed to a workup. And this is a general preoperative evaluation that we do. We do all the X-ray tests that we've talked about. We take a thorough history, find out if they are an alcohol abuser, for example, and we consider ordering all these lab tests: PTH, serum protein electrophoresis. We have picked up over the last 6 months 4 cases of myeloma that were undiagnosed. And so this is why it's important to have some sort of preoperative evaluation. So the whole idea of this is we want to change from bone loss to bone production preoperatively. We want to find out whether their calcium is good, whether their vitamin D3 levels are okay. We want to treat the vitamin D, and you can see these are the risk factors of people that can get vitamin D deficient, which is one of the most common problems. It's better than it used to be, but it's certainly not universally treated by a lot of the primary care doctors. And to summarize this whole thing is we have all these marvelous treatments now that we didn't have just 10 years ago, specifically the anabolic medications that will actually build anywhere from 10 to 21 to 22, even 23% of the bone mass, sometimes within a 4-month period of time, for example, with romosozumab. And so we have the parathyroid analogs, 2 of them now, and of course, romosozumab, and all 3 of these medications can dramatically increase the bone strength so that you can successfully operate on these patients and avoid some of the complications we're going to show you. So we're going to go into case presentations now, and we'll go from there. Feel free to ask any questions while we do this. Okay, who's up?
I can do it.
Okay, go ahead. Ali is one of our excellent fellows we've had this year, and they've matured so much that they're going to help us with some interesting cases we've had.
All right. My first case is a 74-year-old male. He was admitted for spinal stenosis and claudication. He has a grade 1 3/4 spondy. He was initially treated with epidurals. He was unable to walk 10 yards without developing numbness or weakness. No loss of bowel bladder control. He's obese, hypertensive. He also has a high cholesterol, pre-diabetic, but his A1C is under 7. He was scheduled for a L2 to L5 posterior decompression infusion. He developed a infection, and he returned a month later with incapacitating back pain on a walker. So these are his pre-op films. You can see the spondy at 4/5. Here's his
He
CT
developed an
scan.
infection from what?
Excuse me?
You said he developed an infection. You didn't say from what?
A post-operative infection.
Oh, so he had the surgery.
It was a post-op infection. Yes, sir.
Oh, okay. Sorry, I didn't pick up on
Uh,
that.
these are his HUs. You could see at 3, he is an average of 87. So we consider anything under 135 osteoporotic. He also has some fused SI joints. These are some sagittal cuts of his MRI showing severe stenosis at 3/4. This is an actual image showing foraminal stenosis, as well as some central stenosis. These are his post-op images. You could see the screws at 5 pointing down all the way up to 2.
Now that's important, Ellie, right? Because
Yes,
they've
sir.
already shifted.
If you pay attention to 5, we'll see how it looks like um, after the infection.
So this is a gentleman that developed just a postoperative infection with concurrent pretty severe osteoporosis.
So these are when he returned to clinic with his infection, and the screws that were previously at 5 are you could see them pointed with a blue arrow. And the question is what's happening to 5? And so you could see on the CT scan some clear collapse. And on the MRI, you can see a collection going both from 5 all the way up to 1, and it travels posteriorly as well at 4 or 5.
So question, so was this your guys' case?
Yes, this was done at our institution.
So it was all done posteriorly and you had all this data about the osteopenia, osteoporosis ahead of time?
Yeah, I mean, we routinely measure HU preoperatively. We are counseled to definitely take it into consideration.
So again, at our place, this would be unusual, but number one, in the face of the preoperative studies without interbodies. There was no thought of doing interbodies, maybe to decrease I mean, obviously infection is another thing, but with the osteopenia, osteoporosis, to give some anterior load sharing to maybe decrease the chance of hardware failure. No thought of that?
I think I mean, one of the considerations for the interbody is obviously fusion, but we thought there was good alignment here, and so we could get away with a fusion and decompression. Obviously, in hindsight, interbody would have gave more stability in fusion.
Yeah, yeah, but I mean, it would have given more stability, but it wouldn't have prevented the infection. So, you
So
still
Scott,
got.
I don't think that he had a lot of comorbidities, and the thought of the surgeon was, I probably he had adequate, his PI matched his lumbar lordosis, and the thought was we could just do a good posterior lateral fusion with a biologic, except he got it infected, and the infection spread into the disc space. So if he had an interbody, it would be floating around in there, and it's pretty spectacular. The entire, it's an example we thought of a case that. Osteoporosis does not take infections very well. It doesn't have form walls. It doesn't contain it. Doesn't form a Brody's abscess type picture. And this pretty much ate away the entire vertebrae. And so should the HUs be checked? This is why it's important to have a checklist and always on people check and do a DEXA scan and make sure they have one. That's what we tried to do. But people slip through the cracks, as you're going to see. Go ahead, Allie. Sorry.
So this is a sagittal image of the MRI showing how the infection is traveling posteriorly. Obviously, multi-compartmental infection. You could see the psoas lighten up as well. So his diagnosis is osteoporosis, osteomyelitis. He also has instrumentation specifically at L5. He also has AVN at L5 as well. We believe that some of the cause of his osteoporosis, given his age and being a male, is due to low testosterone. And so he has a multifactorial bone failure. So our treatment was we went posteriorly first. We re-instrumented all the way down to the pelvis. And then it was staged with a corpectomy, and a PCO as well as a fusion. And then we did treat him post-operatively with D3, calcium, and anabolic analog. He was also intra-op cultures were taken, and he was given appropriate antibiotics. So this is an intra-op image that we could see posteriorly where we did the decompression. Here are our post-op images from the first stage, where you can see that we use stacked SI screws, as well as we went up to L2 again. We did remove the screws from 5. That shows where 5 was supposed to be, and it still remains until we went anteriorly. That is the remaining vertebra of L5. This is the anterior approach, and you could see coming down on L5, and once we did the corpectomy. This is us filling in the defect in the corpectomy with a expandable cage. These are post-operative images. You could see the cage resting at the end plate at L5. Intraoperatively, we were able to find a firm end plate there, so that we could stack the expandable cage in there. And these are post-op images.
You did pretty good too, Scott. He, my vascular surgeon looked at me and said, "That's all we're getting as far as the
Well, you know,
exposure."
and it's funny. I was about to say, at any time, and it's fortunately been few and far between. We've asked our access surgeons, "Hey, we need to do a corpectomy at L5." They're like, they groan, like, I
Yeah.
don't know.
Well,
It's
I
like
have
the worst level.
an expert guy, and we dug that out, and we basically hollowed out the vertebrae and we sleeved it into the core. But the vertebrae was pulverized, but it had a really good end plate that was very
Mhm.
hard, and we set on it, and the disc was normal there; it hadn't eroded into it yet. But all the vertebrae, because it was so osteoporotic, it just disintegrated. And
Yeah,
put him on
that's a
antibiotics,
tough
he
case.
did pretty good. So
John, if he didn't have that good inferior end plate, would you have just then taken out the 5-1 disc and tried to seat it on the sacrum?
the way you do it, we could not mobilize the left iliac artery and vein; it was stuck, and we would have lost control. And so what you do is you go down in between 5-1 and get a window, and you take the disc out, and then you reach through with an angled curette, and you just hollow right through the end plate and the disc, and then you take the cage and expand it on down through there into the end plate. But it was really, really hard, so we flipped a coin and did what we did.
And do you have any follow-up? It's been 3 months
Yeah.
now. Has the patient
Yeah,
been back for
he's
that?
actually doing very well. He's up walking.
Right.
So, and he is on a alabaloperidotide. So albaltoperidotide, yeah.
What did it grow? Is it just a staff?
I don't remember. Sorry.
Okay.
I think it was just Staph aureus, yeah. But it was MSSA. So it wasn't MRSA. So let's go to the next case, guys.
Okay, I can go next. So I'm Grant. I'm one of the third-year orthopedic residents. And so the case is a 62-year-old male who fell 5 to 6 feet off the ladder onto his buttock on a camper. He was seen in an outside hospital ER and sent home, and then returned and was seen by an outside spine surgeon who recommended bed rest. After which the patient has had no improvement after 4 weeks. During that time, he had a cervical MRI that showed moderate stenosis, and the outside surgeon subsequently recommended a cervical decompression followed by stabilization of his sacral fracture. And of note, he drinks 2 to 6 beers daily.
He's a
So
bud
here
man.
are some. He is. Here are some X-rays of his cervical spine. And then you can see a sagittal and axial cut of his cervical MRI showing a severe stenosis at 6-7. And then here is a, sorry?
Was he progressively myelopathic? Is there some reason they chose to intervene in the cervical spine?
He was not. He had 5 out of 5 strength throughout with his upper extremities, but he was having difficulty walking. And I
Because of
assume that
pain
was
from
there.
because of pain from his lumbar injury or because of his cervical
Yes.
spine?
Yes.
Okay.
And so here are sagittal cuts of his lumbar MRI and CT scan. You can see abnormal bone throughout the MRI, as well as a compression fracture of T12. And here are the Hounsfield units we measured. Again, that compression fracture of T12 is redemonstrated. You can see at L2, average HU is measured at 48.61, as well as L3, we measured 47. And on the right, you can see an average HU of 19. Of note, there's also vertical trabeculae, which shows bony degeneration, where you lose some of the horizontal trabeculae and get increased visibility of the vertical ones. And then here's the sacral fracture. So you can see he has a U-type sacral fracture, which would well explain his inability to walk. And then here in the axial, it's redemonstrated. You can see that again on the coronal and on the 3D reconstruction. So here's what we chose to do. Here's some intraoperative images. We went from L2 to the sacrum with stacked SI screws. There's some intraoperative images after the instrumentation was done. And so postoperatively, we got a venogram due to his immobility for the past month. Surprisingly, it did not show any evidence of DVT. And then again, here are some of his postoperative images we demonstrated.
Yeah, he's walking too now. He
Correct.
got out of bed the next day and walked.
And then here's his postoperative DEXA. So you can see at L1, his T-score was -4. In the left femoral neck, he measured -2.4. Intertrochanteric region, -2.5. And then in the left forearm, he measured -3.5. And so his endocrine workup is still ongoing. He was placed on Timlos, but his PTH, free T4, and TSH were all normal.
So one of the things about this gentleman is the other thing that was a big major concern, Grant. You want to talk about the multi-pronged workup this gentleman's had about his cancers, potential for cancer. So we had him see an oncologist, right?
Right. So an oncologist thought he may have multiple myeloma, recommended an intraoperative biopsy. We did not obtain that at the time. They are planning on getting a bone biopsy postoperatively.
So he basically, we put an endocrinology consult, and our endocrinologist agreed he needed to be started on something, an anabolic, very quickly. And we had the oncologist see him. Actually, did not see him because he came in and was taken to surgery because we needed to stabilize him. And he saw him postoperatively, and he already had a serum protein electrophoresis done that showed no monoclonal bands. And so they repeated that, and that showed the same thing. So he's of low risk for myeloma, and every other bit of his lab has been normal, other than the fact that he is a very heavy drinker. And so they may do a iliac crest or sternal biopsy on him. They haven't decided yet. But it appears that this may be, our thinking is that this is due to more of an osteomalacia kind of situation, where he's been a chronic heavy drinker for his whole life. And basically, as a consequence of that, has shut down his D3 production in his liver, or D2 production in his liver, and basically is chronically low vitamin D and a result in bad bone. So he's been started on the Tymlos at this point. So we caught him early because the reason why we thought, why would a man fall 5 feet onto his buttocks and suffer such a severe fracture? So we looked at his CAT scan and looked at his HUs, and we pretty much immediately made the diagnosis that he's either got metabolic bone disease or severe of some sort, or osteoporosis, or potentially an underlying hemopoietic type disease such as myelodysplasia, which they don't think he has either because all 3 of his cell lines are normal. And so he's a little bit of an enigma, but we just thought it was an interesting case of severe osteoporosis that we had to treat recently.
Well,
We've gotten some questions.
I think that's something that really needs to be emphasized. If the ER guys are not going to do it, but if you're an orthopedist, you get called for a fracture, and of course, the workup in the ER is always going to include a CT scan to do the Hounsfield units, to say, well, let me look at the first thing as part of my workup, besides the fracture, is to see if there's something else going on. And I think that's a huge, really good point, that as orthopedic surgeons going to ERs, seeing these patients, that's part of your initial diagnosis, and it's right there in front of you on the CT scan.
Right.
John, we've gotten some questions in the chat room about thoughts on cement augmentation in these kind of cases where you can't really wait and optimize them.
That's fine. I mean, if you want to use fenestrated screws or do adjacent levels, my understanding is the literature doesn't necessarily support one way or the other, like doing an adjacent level above the end of your UIV, and prevent or tethering or hooks or a lot of other things. It's really kind of equivocal. In this gentleman, we did use hydroxyapatite coated screws because they're easy and simple. They do seem to stick in the bone. You could have used fenestrated screws, would have been another option. And we did use something to boost the fusion, bone morphogenetic protein, because you're in kind of a pickle with this guy. You got to get him fused fast and quick. And there's a little question that it works synergistically probably with some of these parathyroid analogs. So yes, that's certainly an option you could do. Now, we did use a lower modulus rod on him. We do like to believe in construct matching, where we put something that's a little bit more flexible. And the most flexible would be just a pure titanium or a ti-alloy rod versus cobalt chrome or large diameter cobalt chrome, or even stainless steel. Another option potentially could be carbon fiber rods because they have a lower modulus of elasticity than even the titanium rods do. And so there are some things you can think about from that standpoint. Okay, who has the PJK? Which fellow?
But John, as far as screw fixation, you don't have a number at what point you would tend to use cement or tend to use anterior column support?
Well, I think on this guy, if you do anterior, the goal is to boost his fusion and boost his bone quality. I think it's a little bit of a folly to go anteriorly on these people, and we'll show you some cases with anterior interbody, because as we were talking about total dysarthroplasty, the cages will rapidly subside. Particularly, we couldn't use it at 5-1. There was a sacral fracture. And above, we would just make things more rigid above an already fractured area. So my hope is that with the things we've used, we can speed up the rate of fusion. We put him in a brace too. We put him in a TLS full contact brace, basically to give him everything we can to hold him still. And he's been started on a teriparatide.
pile on Jack's question. So preoperatively, is it more important in terms of your planning to augment your screws with cement, the preoperative numbers, or the feel intraoperatively when you're putting the screw in and you're like, ooh, this isn't getting purchased, I need to augment this screw? Which is more of a decision maker?
The latter, because that's exactly what we did. Now,
Okay.
they actually, remarkably, we put large diameter screws as long as we could. We did guide everything, so we put them right up to the front cortex, so we get maximum fixation. And Dr. Sedek did the case with me, and it had pretty good purchase. So we did not augment the screws, other than we did use HA, which has a pretty rapid incorporation to the bone. So that's what we did.
We talked about this a little bit in conference. Do you think that the length of the screw is more important or the diameter?
Diameter. Yeah, most of the fixation is in the with the pedicle. Now, that being said, there are people that certainly believe in triangulation. That if you can put screws in at an angle and bring their tips together, that'll keep them from pulling out more likely too. But I don't know if I don't know if that's really that beneficial. You know, and then you can put like 50 millimeter screws in. I have a hard time seeing where those screws are going. Anything else to add, Paul? You're muted.
Just in the chat.
Just in the chat. All right, let's go on to the next case.
I can
Oh,
go.
sorry.
This is a 65-year-old female who presented to us for a second opinion. She had severe lower back pain and neurogenic claudication as well. She was unable to walk more than 100 feet. She had failed PT, NSAIDs, injections, and other conservative treatments, and notably had a 40-year smoking history, which should ring some alarms, as well as diabetes, hyperlipidemia, and hypertension. So here you can see her plane films, standing films. You can see she has a 4-5 spondylolisthesis. Here is her MRI, and she has multi-level stenosis from L2-3 all the way to L4-5. Her T-scores were, or a DEXA was done showing her T-scores where she has osteopenia. You can see she had a myelo as well. She has a diablock at 4-5 and stenosis at 2-3-3-4. Here you can see it better, CT myelo. And so here are the household units. As we've talked about before, we routinely measure these on our patients, and hers ranged from the high 90s to the low 100s. We measure them on the sagittal and the axial cuts as well. So her case was a debate as far as what levels to do, because her disease is mostly from, as you can see, from L2 to L5. As far as going to the pelvis or stopping at L5, the decision was made to go from fuse from L2 to L5 with decompressions at those levels and a TLIF that was performed at L4-5. Unfortunately, the patient suffered a fall down her stairs. It was about a little over a month after surgery, and you can see failure at that 5-1 level. You can see better on this film where she's had presented a clinic with her standing films, and you can see how she's developed a traumatic spondylolisthesis at L5-S1, unfortunately. This is a bolster film showing that she reduces quite a bit. And then this CT, the axial cut, really gives you a clue as she has these bilateral pedicle fractures. And unfortunately, it is related to her bone quality, and her screws have completely lost purchase at that level. And that is and the result is her traumatic spondylolisthesis. So just to formulate everything, she has bilateral L5 pedicle fractures, traumatic spondylolisthesis, L5-S1, in addition to osteoporosis. And part of the question is this is related to a stress riser at that L5 level. So our treatment was reduction of the spondy, decompression of that bone at L5, in addition to extending her down to the pelvis with S2 fixation, and then starting her on anabolic treatment. So here we did a staged procedure. You can see we went in anteriorly. Let's see if this, hopefully this video plays for you. You can see the fracture of the pedicle. And then here's her final post-op standing films demonstrating bilateral S2 fixation, and she has no pain and she's doing much better.
Great job,
So-
Sachin.
So this lady had not a terrible fall. She was a lifelong smoker, and her T scores, and this was my patient. I agonized about treating her, and her T scores were minus like 2.2. And the problem is, it's very difficult to get those people for 0.3 difference on an anabolic preoperatively. So all you can do is put them on Prolia, which has this whole set of problems because it's one of those forever drugs that you have to, it doesn't really build bone. It just slows the loss. So she would start where she was and end up being slightly, about the same 1, 2, 3, 5 years later. And that's not what we want on these patients. We want to build more bone mass and stronger bone. And so she was denied treatment with those medications, and I took a chance. And she had great lordosis, maxillary pelvic incidence. You can say, well, why didn't you do something anteriorly? That would have boosted the fusion rate, but it probably would not have necessarily prevented an L5S1 fracture because she didn't have stenosis there and weren't going to do anything there. And so these are the conundrums you run into when you start thinking about what you should have, could have, would have done on some of these cases. And I've thought a lot about all these cases we're presenting about what we could have done differently. And sometimes, even though you may do the proper thing, you may still get an osteoporotic complication. So keep that in mind. So you want to present? Who's next?
I will go next.
Chris is next.
Sure. So I will present a 65-year-old patient with a previous L2 to 5 front and back decompression and fusion. So the patient came back with severe low back pain, radiating bilaterally to her legs. She tried some non-operative treatments, anti-inflammatories, going to physical therapy, and was also seeing a pain management doctor, but without much relief. She denied any weakness or any bowel bladder issues, but she's having severe neurogenic claudication and cannot walk distances. She's diabetic with a hemoglobin A1C of 7%, which is reasonably well controlled. And her symptoms were severe enough to affect her daily activities and her quality of life. These are the pre-op X-rays. She has solid fusion between L2 to 5, but we see kyphosis at the proximal junction with some degeneration. This is the myelogram. We see severe adjacent level problems with a vacuum disc and some stenosis at the superior adjacent level. We obtained DEXA scans. So these scans were obtained from the hip bilaterally, hips bilaterally. The right hip shows a total proximal femur T-score of minus 1.8 and a femur neck T-score of minus 2.1. And the left hip shows a total T-score of minus 1.5 and femoral neck T-score of minus 1.6, which are all these T-scores are within osteopenic range, not osteoporosis. But when we look closely on this patient's CT scans, we see that her Hounsfield units are below 100 at almost all the levels. As we can see, T11 has an average Hounsfield unit measurement of 66, and T12 has a measurement of 91, which are below 100, and which are typically lower than what we expect to see in a patient with just osteopenia and not osteoporosis. And we see this discrepancy very often. There's probably not a very good answer to why this happens, but we see this quite often in our clinic. These are more cuts from her CT scans. So we decided to operate and extend the fusion up to T11, I'm sorry, T12. We see immediate post-op standing X-rays here. Her spinal alignment is good. The fixation looks good. We also extended the fusion caudally to her pelvis. She did fine for about 6 weeks post-op, but then she came back with sudden onset of low back pain, accompanied by severe deformity, a kyphotic deformity that is visible on her back. As we see here, she developed a proximal junctional kyphosis of over 50 degrees with severe positive sagittal imbalance. We took a CT scan, which shows a proximal junctional failure with the T12 screws cutting out through the superior end plate with severe PJK at that level. Also, the right side, the upper screw on the right side cut out medially through the spinal canal. So we diagnosed a patient with proximal junctional kyphosis and failure with acute instrumentation failure. There was also severe instability at that level, accompanied by severe stenosis and symptoms related with stenosis. Also, what was overlooked at the first surgery is that she had untreated pre-existing osteopenia, osteomalacia. We extended her fusion both cranially and caudally, and we decompressed the level where the junctional failure happened. We also started her on anabolic treatment supported by vitamin D and calcium, and we also wanted to support this construct with a TLSO brace for a short period postoperatively. These are her post-op X-rays. We had to extend the fusion up to T4. Since this was an acute problem, she reduced pretty nicely at that proximal junction that had almost 60 degrees of kyphosis. She reduced nicely at that level, but we had to go up to T4. And the junction where the previous failure happened was supported with was spanned with multiple rods. Okay, thank you so much.
Good job. On all so far, everybody's done a great job. This case is prototypical for what we see, and we've all seen many of these cases with ourselves and our partners. Wouldn't you say, Riza?
Yes, sir. We see quite a few of these cases, unfortunately.
Can I ask a question? This is definitely off my lane, but for John or Jens, whoever's on. So the first failure was proximal, and there were two proximal failures, and you had a degenerative 5-1 disc that probably wasn't moving. What's the rationale for the distal extension? Because it seems to be a pretty stable segment at 5-1 where all the pathology was proximal. And we see, I mean, again, the preface is when I see my deformity colleagues at TBI treat this problem, they do the exact same thing. And I've never really been able to get an answer if the
Are you talking
problem
about
is
the previous two
proximal.
cases?
Huh?
You're talking about the previous two, L2 to 5?
Well, this case, as it failed the second time, I understand, but the first time it failed proximally, but 5-1 was kind of a stable joint. What's the rationale? But like I said, the preface is my colleagues in deformity at TBI do the same thing. If that was the same case, they would do the exact same T10 to the pelvis, but it looked like 5-1 was kind of a stable degenerative situation. So is that just kind of the teaching at this point, or?
Well, in this case, the disc is very degenerative, and the lordosis is not adequate despite having an anterior procedure. And so the lordosis is 20 degrees, and the PI on this patient is probably 55 degrees. So you've got a significant mismatch.
So
And
you're trying
alignment
to,
isn't everything.
okay, so you're trying to regain a lot of lordosis through the 5-1, because just as it's degenerative doesn't mean it's symptomatic, correct? Do you agree?
Absolutely. 5-1 has big iliolumbar ligaments, and it's a very
Yeah.
stable joint. And that's why a lot of times you wear out at 4-5 and above, and you have a nice disc there. The question is, how many levels can you go above a reasonably healthy L5-S1 disc without having to go to the sacrum? And
Okay.
a lot of people will say L3. If you go to L3, you got to go to the sacrum. And at our facility, we almost certainly would do that person anteriorly at L4, 5, and 5-1, both for fusion, because 5-1 does not fuse with the T-lift very well when you have a long construct above. I think that's been pretty well shown. And we would do that for fusion also. Particularly multi-levels, we do a fusion boost in the front. And so I think it's a lot to think about, and you got to think about it right, you get it wrong. In this particular patient, this patient was not measured for Hounslow units above. And when we measured them after the fact, it was 60 and 50 and 40, and it was pretty low in depth or definitively in the osteoporotic range. And we thought it was a good example of how important it is that even if you align people well, you don't see this kind of problem in pediatric patients that have severe deformities at all. They fuse, they don't get PJK very often, and if they do, it's inconsequential for most of them. But something's different in adults. And the one common factor, the thread that goes through all these patients, in my mind, is the fact they almost always have poor bone quality. And most importantly, after the age of 30, extremely poor fusion capability and bone healing. And so we presented this case mainly from that aspect. Okay, let's go to the final
Get it.
case.
Thank you. Yeah, I get it.
Get another case. Who's next? Or have we done them all? Oh, here we go.
All right. No, we have one more.
Okay, let's go.
All right.
That's
My name's
10
Justin
minutes.
Vickery, one of the fellows as well. I know we're coming up on end of time, so we'll go through this one kind of fast. This is a case of a 67-year-old female who presented for a second opinion. She was coming in with some left leg pain that was acute on chronic. She did have a prior 5-1 decompression, was having troubles with activities of daily living at this time, says her quality of life was significantly affected. She had exhausted non-operative management when she came to us. She was also evaluated for osteoporosis, did have a history of fragility fracture, previously low vitamin D. Menopause was at age 45, smoking history, and past history of alcohol abuse as well. We did recommend treatment for her osteoporosis, but she refused at that time. And so a small one-level surgery was recommended for her. Here are her preoperative standing x-rays. You can see the spondylosis mostly at 5-1 with the anterior listhesis. This is her MRI. She did get a CT myelogram as well. And I believe this cut was at 3-4, but given her comorbidities, and her symptoms mainly being a radiculopathy, I think the decision was made to just address 5-1, which was the surgery offered. Here you can see we measured her Hounsfield nuisance and multiple levels ranging in the 40s to 60s. So she underwent this surgery here, ALIF at 5-1, followed by posterior spinal fusion. She presented for follow-up, and I believe this was the 2 to 3 week range post-op, complaining of new sudden onset, severe low back sacral pain. Now you can see on these x-rays, I'm not sure if my cursor is showing up, the fracture of the sacrum present there. CT scan was obtained, which better demonstrated the fracture. So at this point, she had a post-op complex sacral fracture with spondylolisthesis, in addition to her known severe osteoporosis. So she underwent revision surgery, where she was extended up, as well as with the addition of stacked S2AI screws. She was also started on treatment for her osteoporosis as well. I believe that's the last slide.
So any questions about these cases at all?
Yeah, so great cases, nice presentation. Sorry I came late. I struggled with a robot. I'm going back to Flora. We had a horrible delay with our robot. I apologize so much. Great topic. Thank you for bringing that up. For me, the big question is what I'm seeing here is we talk about mismatch a lot in terms of alignments, but osteoporotic bone and fusions don't like one another very well. And so my question really is if we have to fuse what to do in terms of precautions or looking at non-fusion options, Richard Chewer, for instance, and I agreed in the chat room, maybe some decompressions and all those people are more suitable. In this patient, and this is the overlooked bone density measurement, was the sacral ala looked at? Because when you have these vacuum ala with just fat in there, with a Hounsfield unit of not measurable, those are patients that probably don't do very well with an L5 as one segmental fixation. So any thoughts on the ala bone and any thoughts about maybe expanding indications for decompressions only in people who have more stenosis or stable spondies? Two divergent questions. I apologize.
Well, I agree with you about the sacral ala having a hole in it and being quite osteoporotic, but we don't really, you measure the Hounsfield units and it's quite low, but we don't know how to interpret that. And as far as too many fusions being done at too many levels, I think that's probably a astute observation.
There's the old paradigm, and I'm obviously an older surgeon. As a young surgeon, you fuse. As an intermediate surgeon, you refuse. And as an older surgeon, you refuse to fuse. So.
No, you get young partners to do it for you.
No, but those are all very illustrative cases. And again, for me, the key thing now, and I don't want to get into names here, but medical legally, I know of some landmark cases in our country where some major names in deformity surgery outside of John testified that in postmenopausal osteoporotic females, you should go to the pelvis for multi-level fixation. So that's kind of becoming more and more common now. And there are a lot of companies that basically have jumped on that. I don't want to mention their names, but
I don't think you're wrong with that. I just think that you ought to. That's fine, but you ought to pre-treat those patients for their osteoporosis before you go to the sacrum. Yeah, yeah.
This is my bandwagon thing. Why are we not banding together and asking our radiologists to routinely do opportunistic CT measurements for Hounsfield units on patients to then put that in the report, whether it's a chest CT or an abdominal CT or whatever it is, and put these at-risk patients into a organized algorithm so that their PCPs can start them on anti-osteoporosis drugs. This should not be just
some of ours do. Some of our guys, I've talked to them, and some of them actually will put it on their reports. Not all of them. I think in summary, I mean, I know we're up on time. In summary, I think the most important thing that you should think about is when somebody says, well, why did you operate on that person if they're so osteoporotic? The answer you don't want to give that was given to me was, I thought I could get away with it. Okay. I think that's a dangerous answer. And particularly in this day and age, I think it is going to be important that if you get a catastrophic PJK or something, and they've got really bad osteoporosis, that you could potentially be in a little bit of questionable, get questioned about that. So that's what I would say.
I think to the extent that this particular Seattle Science will get, looked at a lot on social media and YouTube is the importance that you guys did on preoperative assessment of osteopenia, osteoporosis. There's too many But there are a lot of community surgeons that just look at the deformity, the sagittal balance, and this and that. And if you don't take into account their bone health, you're going to increase your failures. And those are the ones that end up in the large, centers like, Leatherman and Seattle and TBI and things like that. We want to have less failures out there. And thank you for putting that out there, because not enough people focus on that as part of the workup when we're doing these reconstructions.
And I also think having that liaison group of people who can medically evaluate and treat the patients hand in hand with your surgical plan is important if you're going to be in this business. And just to repeat what Scott said, we can't just keep thinking as carpenters. The older guys here, our training was woefully poor in the metabolism of bone and osteoporosis. The Own the Bone, came up 15 or 20 years ago through AAOS. So I think the younger guys are inculcated much better than we were in residency, with thinking more about of the bone as more than just a substrate to put a screw into.
Yeah, we for example, fracture liaison service. I'll say one other thing is we're going to basically take all our fractured hips that come in that are basically osteoporotic fractures. And those people are automatically going to be referred, hopefully over the next year or two, for evaluation and treatment. And that should happen also. We're going to do it with compression fractures also.
Such an important topic. Thank you, Dr. Dimar. Thank you for it. Norton, Leatherman, you guys are fantastic. Always great stuff. And join us tomorrow night, by the way, 5:15 for an evening with a spine surgeon with Dr. Chris Shaffrey, the only ortho neuro double-boarded surgeon and one of our leaders, the only recipient spine surgeon of the Harvey Cushing Medal. So please join us tonight, but thank you tonight.
Thank you, everybody.
Bye-bye.
Have a good night. Stay well. See you tomorrow night.
Thanks, team.
Thank you. That was great.
Bye-bye.
Bye.